Hello everyone and welcome. I'm Kimberly Gonzalez, Manager of Value-Based Performance Analysis and Improvement at ABC Network. Today's walkthrough introduces the MSSP Quarterly High Risk Workbook, or HRWB. This training is designed to help you understand what the High Risk Workbook represents, how you can use it to interpret risk scores responsibly, and how to use this workbook to prioritize proactive care. This is not a compliance or audit training. The focus is on population-level insight and intentional action. High-risk beneficiaries shape MSSP outcomes. A relatively small number of beneficiaries tend to drive emergency department visits, admission and readmissions, care fragmentation, and disproportionate cost. Risk rarely escalates because of a single event. It builds when clinical complexity, utilization, and social factors overlap. The High Risk Workbook helps us act before avoidable utilization occurs.
How does the HRWB add value beyond utilization reports we already receive?
Utilization reports tend to be retrospective and siloed. The High Risk Workbook integrates utilization with clinical burden, social risk, and cost context, allowing us to identify vulnerability before utilization becomes recurrent or expensive. The High Risk Workbook is a consolidated population-level risk stratification tool. Each row represents one Medicare beneficiary. The workbook brings together multiple risk domains into a single view. Those risk indicators are translated into points which roll up into a total risk score. That score then determines a risk classification. The goal is to provide a shared, consistent understanding of who is most likely to benefit from proactive support.
How should we think about HRWB risk scores relative to clinical risk scores or EHR-based stratification?
The High Risk Workbook does not replace clinical risk scoring. It complements it by incorporating claims-based utilization, cost signals, and social risks that may not yet be visible in the EHR or CMS risk scores. It's most powerful when used alongside clinical judgment, not instead of it. Risk in the High Risk Workbook is intentionally multidimensional. We evaluate 4 primary domains. First, utilization risk, including ED visits, inpatient admissions, and readmissions, with attention to frequency and recency. Second, clinical burden, such as chronic condition count, comorbidity clustering, and long-term complexity. Third, social risk, including housing or economic instability, limitations in primary support, and environmental or access barriers. And lastly, financial risk, including year-to-date total cost and cost percentile relative to peers. Risk increases most when these domains overlap, not when they appear in isolation.
Do we weigh certain domains more heavily than others when interpreting this report?
The report does not prescribe a single dominant domain. Interpretation should focus on overlap. A beneficiary with moderate signals across multiple domains often warrants more attention than one extreme signal in isolation. Risk scoring in the High Risk Workbook reflects direction and intensity, not certainty. Each domain contributes points based on factors like severity, frequency, concentration. Those points are summed into total risk points, which determine whether a beneficiary is classified as high, moderate, or low risk. It's important to remember that risk points are directional indicators. They guide prioritization. They do not predict guaranteed outcomes.
How stable are risk scores over time, and how should we interpret movement?
Score movement should be interpreted directionally. Increases may reflect new utilization, emerging social risk, or accumulating complexity. Decreases don't necessarily mean risk has resolved. They may reflect timing or claims lag. Trends matter more than single quarter changes. In the High Risk Workbook, high risk is a prioritization signal, not a label. It reflects multiple converging risk drivers that indicate increased vulnerability, higher likelihood of utilization if unaddressed, greater potential benefit from proactive engagement. High risk does not mean poor behavior, poor care, or inevitable hospitalization. It means this individual may benefit from closer attention and coordinated care. It's critical to understand how data timing affects this workbook. The High Risk Workbook relies heavily on claims data, which naturally lags, typically by 30 to 60 days. As a result, some utilization events may appear after outreach has already occurred. reflect episodes of care that have since resolved. This is why we recommend pairing high-risk workbook insights with current clinical context, focusing on patterns rather than single dates, and avoiding reactive conclusions. The high-risk workbook is designed to support intentional, proactive use cases, including care management enrollment decisions, high-risk outreach prioritization, post-ED and post-discharge follow-up, SDOH referrals and community resource linkage, multidisciplinary risk huddles, leadership and ACO level planning. The workbook supports alignment and planning, not enforcement.
Can this report be used to evaluate program performance or intervention ROI?
Indirectly, yes. At an aggregate level, it can help assess whether high-risk cohorts are stabilizing over time. It should not be used to evaluate individual team or provider performance. Next, we'll walk through the high-risk workbook using a demo file for Sunshine Community Health Center. This is fictional data created solely for training purposes. No real patient information is included. During this walkthrough, the goal is not to memorize columns, but to understand how to read the workbook confidently. There are 4 key tabs you'll work with. The Cover tab provides purpose, scope, and important reminders. The Analysis tab shows population-level signals and dominant risk drivers. The Detail tab includes beneficiary-level risk components. And the Data Dictionary defines each field and outlines intended use. Best practice is always to start with the Analysis tab before reviewing individual records. Now, let's look at our Sunshine Community Health Center high-risk workbook demo. First, we'll start with the cover page. The cover page lets you know the reporting period for the report. This report is for Q1 2026 using claims data through January up until March 2026. The high-risk workbook is intended to identify Medicare beneficiaries with elevated clinical, utilization, social, and cost-based risk. The intended use of this report is to have timely outreach and care coordination, ensuring that we can reduce avoidable ED visits, admissions, and readmissions, as well as cost. The high-risk workbook represents 1 row per 1 beneficiary. Data is aggregated across multiple risk domains, and risk indicators are rolled up into total risk score to classify beneficiaries as low, moderate, or high risk. The High Risk Workbook provides a single, consolidated view of risk to support care team decision-making. The key domains included in our high-risk evaluation include utilization, clinical burden, social risk, and financial risk. Because claims data is lagging, some utilization or cost events may appear after care has already occurred. The intended use of this report is to support care management, high utilizer outreach, SDOH referrals, PCP and care team risk huddles, and ACO level population health strategy and reporting. Jumping to our Analysis tab. This breaks down the data of your entire population into manageable pieces that you can look at. Table 1 represents the beneficiary count for the high-risk workbook for Sunshine Community Health Center. This shows that they have 23 high-risk beneficiaries, accounting for 25% of their total health center population. The average risk points are 18.76, with the max risk point being 21. This shows us that our population is skewing towards rising risk. Table 2 shows utilization summary. This lets us know that for Sunshine Community Health Center, the average year-to-date ED visits are 0.52. Of the 23 beneficiaries identified as high risk, 3 are ED high utilizers, meaning that they have more than 2 ED visits year-to-date. They account for 13% of the total beneficiaries. Average year-to-date IP visits is 1.22, with 4 IP high utilizers, meaning that they've had 2 or more IP admissions year-to-date. They account for 17% of the high-risk beneficiaries. Next, we have our chronic condition burden table. This shows us that the average CC count is 10.92, with an average of 65% of the high-risk beneficiaries having more than 10 CCs. The average CC points are 8.98, signifying that this population has a high clinical complexity. For social risk summary, we see that 30% of the high-risk beneficiaries have more than 1 SDOH, none have more than 3, and our average SDOH points are 0.52. Our cost summary shows us the year-to-date average cost for this population being $28,000, the lowest year-to-date cost being $2,000, and our highest being $100,000. To the right, you will see immediate leadership signals. This shows you prioritization groupings that you can use for outreach. This helps reduce your overall workbook into manageable sizes that you can prioritize first. First are your ED high utilizers with no PCP engagement. Next is your IP high utilizers with multiple comorbidities, meaning that they have more than 5 CCs. Next is your high cost, accounting for the top 25% who have no PCP engagement. Next is your high risk beneficiaries with no assigned PCP. And next is your high SDOH burden, meaning that they have more than 3 SDOHs and they have clinical complexity, having more than 5 chronic conditions. These members are driving avoidable acute utilization if they do not receive continuous care. Next, let's jump into our beneficiary detail seen in the Q1 2026 tab. This shows you all the high-risk beneficiaries assigned to Sunshine Community Health Center. First, you'll see the demographics tab giving you the beneficiary's Medicare ID, their first and last name, and their date of birth. Next, you'll see their care accountability. This lets you know the accountable health center, their accountable PCP as documented in the EHR, their eligibility flag, their PY 2026 encounter flag. This lets you know whether a beneficiary has had an encounter with the provider at your health center in 2026. Next is your social determinants of health. This lets you know the SDOH count for those beneficiaries as documented by Z codes in claims. Then we let you know the corresponding SDOH categories that were documented as being present issues for this beneficiary, and then the attributed SDOH points for this category. Next, we see the utilization. This lets you know year-to-date ED visit, the latest ED visit and its corresponding diagnosis code, then a high utilizer flag. This lets you know whether a beneficiary has had more than 2+ ED visits year-to-date. Then we see the corresponding ED points for this category. Next, you'll see the year-to-date IP visit count, year-to-date readmissions within 30 days, the latest inpatient visit with its corresponding diagnosis code, and then a high utilizer flag, letting you know whether or not the beneficiary has had more than 2 IP visits year-to-date. Then we see the corresponding inpatient points. Next, we have our chronic conditions. This lets you know the chronic condition count for the beneficiary, the list of their chronic conditions. Keep in mind, this list is separated by a semicolon. Next, we see the chronic condition points for this category based on the chronic conditions and their complexity. Next, we see our year-to-date total cost, what percentile band this is of the entire population, and the cost points associated based on the year-to-date cost and the percentile band. Lastly, all the category points will sum up into the total risk points. These have been sorted from highest to low, letting you know that all beneficiaries here are risk classified as high risk. Going back to what we saw earlier in our analysis tab, the immediate leadership signals can be seen here in the immediate leadership signals column. This lets you know which priorities you want to focus on. For example, if you want to look at beneficiaries who have a high SDOH burden and are clinically complex, you can filter this column to only look at beneficiaries with the E leadership signal. This will highlight beneficiaries who have high SDOH burden and are clinically complex. Next, you will see that some beneficiaries have multiple leadership signals, meaning that they have multiple different priorities that can be addressed at the same time. For example, this beneficiary belongs to the ED high utilizer, IP high utilizer, multiple comorbidities, and is high cost. These are the beneficiaries that you want to focus on first, especially since they have multiple signals that indicate their high risk classification could possibly worsen without proactive care management. Next, you'll see that we left a couple columns for your feedback. This will let us know whether or not a care manager has been assigned to this beneficiary, and then if you have any additional notes that you would like us to incorporate into the beneficiary's record. This can be returned once you have done a full review of your High Risk Workbook to ABC Network. Lastly, you will see the Data Dictionary tab. This lets you know the field definitions for everything that you see in the Q1 2026 tab. This will account by different categories as you saw highlighted in the first row. You'll have the field name and then their definition and why it matters or how it is intended to be used. Keep in mind, this does go through specific examples. So for SDOH categories, you'll see housing, economic, employment, social environment, primary support, and other psychosocial factors. This helps you better understand what we mean when we say SDOH categories. And this is how you should be using this data dictionary to better understand the data you're seeing in Q1 2026. Now let's focus on how to turn this data into action. First, sort by total risk points from highest to low. Higher scores indicate a greater concentration of risk drivers across the multiple domains. Next, look for overlap across the domains. Prioritize beneficiaries with combinations such as utilization plus chronic conditions plus social risk, or utilization plus social risk. Then you can use recent utilization for relevance, as recent ED visits or inpatient stays often signal higher short-term intervention value. Finally, you can group by patterns before reviewing individuals. This can be assessed using the leadership signals provided in the Analysis tab. The High Risk Workbook is designed to highlight common risk profiles, not just individual outliers.
How do we avoid chasing the highest scores every quarter?
By anchoring outreach strategy to risk profiles, not just rank. The same beneficiary remaining high risk may indicate appropriate complexity, not failure. The more important signal is whether new beneficiaries are entering higher risk tiers. Let's close with the practical action checklist. Use the High Risk Workbook to focus first on beneficiaries with multiple risk drivers. Review trends at the population or provider level before drilling down. Pair High Risk Workbook insights with Chronic Condition Workbook context to understand underlying complexity. Use risk classification to prioritize outreach, not label patients. Align care management capacity to actual risk intensity. Revisit the High Risk Workbook quarterly to identify shifts and emerging risk. The goal is proactive, patient-centered care, not volume or compliance. Each MSSP report answers a different question. The attribution roster tells us who is aligned. The CCW helps explain how clinically complex the population is from a risk adjustment perspective. The High Risk Workbook shows who is most vulnerable right now, and the Care Gap report defines what actions remain open. Together, these reports tell a complete, connected story. This concludes the High Risk Workbook walkthrough. If you have questions or would like support reviewing your site-specific High Risk Workbook, please reach out. I'm Kimberly Gonzalez, and you can contact me at kgonzalez@azbestcare.org. Thank you for your time and for your ongoing support for our Medicare population.